Module 4, Renal System. So we're going to talk about coordinating care for patients with renal disorders, which is chapter 62 in your FA textbook. Moving on to polycystic kidney disease, or PKD. This is a genetic disorder that's progressive, so it's going to get worse over time. We know that. Anything genetic, we want to think about family history, family genetic testing, stuff like that. So this is going to cause excessive growth of fluid-filled cysts in the kidneys. Plain and simple, these little cysts start off microscopically, they get bigger and bigger and bigger, and they pretty much just rip through the kidneys. Pathophys, these cysts start in the renal tubule of the nephron, again, microscopic, really tiny. They eventually will separate, leaving a big sac. They get really big, they compress the structures of the kidney, the tissue, and it just destroys the kidney. Eventually, it's going to probably lead for most patients to renal failure. There are two forms, child and adult. Again, this is an adult class, so you don't have to worry too much about the child kind. That's autosomal recessive, less common, and it happens really fast. It progresses really quickly. The adult kind is autosomal dominant polycystic kidney disease, which is ADPKD. You can be born, you're born with it. It kind of lays dormant and doesn't come out until around 30 to 40 years old. This is multisystemic, so it doesn't only affect the kidneys, but it can also affect other major organs like the liver, spleen, and pancreas. So PKD will progress to end-stage renal disease in about half of the patients by the age of 60. So signs and symptoms, you're not going to really see many signs and symptoms until those cysts get pretty big and they start pushing on the structures of the kidney. The first symptom, though, is going to be hypertension. So if you already have a patient who has a genetic family history of PKD, then you really want to pay close attention to that blood pressure. Hematuria, blood in the urine, lower back or flank pain, headaches, abdominal pain, palpable large and enlarged kidneys. So remember, this is something symmetrical. This is this is happening to both kidneys. It's not just one kidney. Diagnosis, history and physical, of course, family history. We can see urine and bacteria in the urine. Definitive is going to be imaging to actually take a look to see the presence of those cysts, and that can be done through ultrasound, MRI, IVP, which is an intravenous pyelogram, or CT scan. So pictured here is an IVP, a pyelogram. It's done in interventional radiology. You can see the patient is getting a dye injected, and then x-rays are taken, of the vessels lit up, and you can see the vasculature of the kidney. Treatment for PKD, now hemodialysis, or peritoneal dialysis, and that's if it progresses to end-stage renal disease. So that makes sense. Your kidneys aren't working. We're going to need some other way to filter the blood. These patients may need eventual dialysis. Managing this disease, urinary tract infections, regular checkups, and immediate treatment with antibiotics, because polycystic kidney disease does not result in infection. The condition itself is not infection. However, we don't want infection of the urinary system. It can exacerbate the whole condition. So we want to make sure UTIs are managed, immediate antibiotics on board if they get a UTI. Pain, having this tissue, this kidney tissue injured and expanded and these big cysts, it can cause a lot of pain. So for this one, because it can be severe, we can give non-narcotics and narcotics. Okay, so your Tylenol, your non-opioids, and your opioids like acetaminophen, Tylenol, or morphine. This may also require surgical intervention via a nephrectomy. So nephrectomy is removal of partial or the whole kidney, and that just depends on how severe it is at that moment and what is best for the patient's goals, related to, what else is going on in their body. Hypertension, again, always think of possibility of high blood pressure with polycystic kidney disease. Medications, so ACE inhibitors, angiotensin receptor blockers, low sodium diet, exercise, and smoking cessation. Smoking wreaks havoc on the body, it constricts blood vessels, and we don't need that with polycystic kidney disease. The only cure for this is to remove the kidney and to have a kidney transplant. So complications, severe hypertension. Again, you're hearing hypertension, really important. Assessing those vital signs, anticipating that this may happen with these patients. Renal stones, recurrent UTIs, hematuria, heart problems, specifically with those valves related to this really severe hypertension. So the assessments, vital signs, temperature. We want to make sure that they don't get an infection. So if you see a high temperature, then we need to treat that right away. Blood pressure, oxygenation, daily weight, because we're talking about kidneys that may not be working as well. They might be in fluid overload because the kidneys aren't able to make urine. And then our labs, hematocrit, hemoglobin and hematocrit, to see what the concentration is, creatinine and BUN, and now we're adding in our electrolytes, so sodium, potassium, calcium, phosphate, and that's because our kidneys are not working. So we know that some electrolytes are going to stay in and some are going to leave the body. So we want to keep an eye on those electrolytes, UA, and urine CNS if we suspect infection. Interventions, likely fluid restriction. Again, this depends on the stage in the disease, but with this we're thinking they have progressed to having renal impairment. So with renal impairment, we are going to restrict fluid, limit protein. We want to give the kidneys kind of a rest, so we don't want to bombard it with things that it needs to try to process. So protein, potassium, phosphorus, and sodium. Patients with kidney issues have increased potassium and phosphorus, and the sodium part attracts fluid, and fluid isn't coming out of the body that well, so we also want to restrict fluid. Medications for blood pressure, infection, and pain meds, and then we want to educate on compliance so that they follow the plan of care and keep them out of the hospital. And this is a picture of really, really large cystic kidneys. Okay, pyelonephritis. So what is pyelonephritis? So this is inflammation of the renal parenchyma and renal collecting system. So this is the actual kidney tissue itself, like pictured here, the actual kidney tissue. Risk factors. If you've had a lot of UTIs in the past, pregnancy, any type of obstruction that would cause backflow of urine back up to the kidneys, long-term catheter use, urinary catheter use, and sexual activity. So it usually will stem from a UTI. Bacteria is introduced into the urethra and it just kind of makes its way up all the way up to the kidneys and causes an infection. E. coli is the most common cause of pyelonephritis, and it's also the most common cause of a UTI. Okay, it goes hand in hand. And E. coli is in stool, it's in feces. So this is an education point for you to teach your patient. Wipe for females, wipe from front to back, really good hand hygiene. After sexual activity, it's helpful to void afterwards. It's one of our immune defenses to clean that urinary tract of any kind of pathogens that might be lingering around. Signs and symptoms, this is an infection, so you're going to see those typical infection signs like fever, chills, nausea, vomiting. Our kidneys are going to be angry and upset and sad, so that back pain, that flank pain, costovertebral tenderness, and could be enlarged kidneys too from all of that inflammation. Diagnosis H&P, our labs are going to show a shift to the left, so we are going to have a high WBC count, which is a high white blood cell count, but the shift to the left is referring to an increased amount of immature neutrophils, which are our first responders. So the body is prepping the soldiers. They're making a lot of little baby soldiers, and we can see that in the labs. So when you see, again, review, shift to the left indicates that there is an infectious process happening. We can also look at the urine, a UA, a urine analysis. So that's going to start with you just looking at it. Pyuria, so that is going to be purulent or pus inside of the urine, bacteria, and blood. We can see, again, checking the WBC. We can culture that urine. We could take blood cultures because remember, pyelonephritis is serious. This needs to be really taken care of quickly with antibiotics, IV antibiotics, because it can lead to urosepsis, and that can be lethal. Again, treatment in the hospital. They should be admitted so that they can get lots of hydration, antibiotics. Now remember, pyelonephritis is not an issue with renal function. So we're not holding back fluids. This is just an infection in the kidney. We want to flush the kidneys out. So we should encourage not only oral, but also IV fluid. And then we're going to get antibiotics on board, such as Cipro or Bactrim. And then surgical management may be necessary if it progresses more severe or there's like some type of obstruction, the pain doesn't go away, they develop a pocket of purulent fluid, like an abscess inside, then that would warrant surgery. So complications. An infection in the kidney itself, especially if it's caught later and not treated early, can cause permanent damage, scars in the tissue. It can lead to chronic kidney disease, which is going to be lifelong kidney impairment. Urosepsis. Okay, so urosepsis is not the focus of what we're talking about, but it is a complication, so you should be aware. So urosepsis, uro means that it is coming from the urinary system, the renal or urinary system somewhere. Sepsis means that there is a blood infection present and there's this massive reaction from the body that's going to lead to death if left untreated. So changes in mental status, fever, tachycardia, tachypnea, hypotension, low urine output, and leukopenia. Okay, so nursing interventions, antibiotics are going to be your priority for this. Then pain management and hydration. Okay, but that number one, antibiotics, because we know if we don't stop that infection, it can lead to permanent kidney damage and death. So teaching, because the number one risk factor of pyelonephritis is UTIs, then we want to really educate the patient on how to prevent that from happening in the first place, especially those that are pregnant too, because they're at higher risk for UTIs during pregnancy, because that bladder isn't emptying as it should. Sometimes as the baby grows and grows and grows, you get stagnant urine in the bladder that can lead to infection. And on top of the female's urethra being much shorter, that is a recipe for disaster. So this box, teaching measures to reduce the incidence of your UTIs, really, really good information there. It's straight from your textbook. Please read that over. We're moving on to the glomerulus, and we talked about the glomerulus in our assessment and function chapter. So just a quick little review, we have our ball of capillaries here that is receiving oxygen-rich, nutrient-rich blood from our aorta, and through hydrostatic pressure, it's going to push out solutes through that semi-permeable membrane of the capillaries, which will then be all caught by that Bowman's capsule, which is this yellow, literally a capsule that encapsulates that ball of capillaries, which then it will head down into the renal tubules. Well, then the body is going to decide whether it is reabsorbed, secreted, and what is sent out of the body as urine. And then we measure this with the glomerular filtration rate, which is GFR. Acute glomerulonephritis. So just by the name says, the glomerulus is upset, it is angry, and it's inflamed and infected. So the pathophys, how does this happen? So we again have an inflammation of the glomeruli within the Bowman's capsule of the kidney. It's triggered by some type of immune response, and it's the third leading cause of renal failure in the United States. So the prognosis of this, the outcome of a patient who has this, is just really going to depend on what caused it in the first place, what pathogen, and how long it's been brewing in there and how much damage it's caused. This is common in children and young adults. So risk factors for this, acute glomerulonephritis, recent infections. Example, strep is one of those, it's like a strep throat. So the number one risk factor is infections. So a number one education point is to keep the patient well so that they don't get sick in the first place. Very, very important with acute glomerulonephritis. And also like hand washing, all of those things that we do, we tell the patient, so they don't get sick. This is going to apply to acute glomerulonephritis. Okay, also immune diseases like lupus, vasculitis, hypertension, diabetes. All of these things can cause this immune response, and for these little immune complexes to kind of collect in the glomerulus and cause this inflammation and infection. So now let's talk about the signs and symptoms of acute glomerulonephritis. So you're going to have things coming out in the urine that are not supposed to be there, and that is going to be a direct result of increased permeability in those capillary walls. Remember, glomerulus is a big ball of capillaries, and it produces filtrate of only specific solutes that can pass through. Well, when it's inflamed, it starts to open up a little bit more, and solutes that normally don't come through are going to come through, and you're going to see that in the urine. So you're going to have protein, blood, white blood cells in the urine, and you're also going to see casts. So casts are pictured here, and these are just made up of all of those extra things kind of sticking together, and they refer to them as casts. Specifically to glomerulonephritis are erythrocyte casts. So remember that, erythrocyte casts, if you see them in the urine, it's pointing towards glomerulonephritis. Other signs and symptoms, generalized body edema, and that's because the fluid is staying in the body, it's not leaving the body. Patient's going to experience retention. Decreased urine output, hematuria, hypertension. Patient will be excreting protein in the urine, and depending on how bad it is, will determine how much protein you see in the urine. And then, of course, our BUN and creatinine are both going to be elevated because they're going to, with this condition, they have impaired renal function. So diagnosis, medical history, you're going to ask questions. Did you have a recent infection, especially a strep infection? Physical exam, labs. There are specific labs that can look to see if that immune response. Assessments. So we're doing daily weights. Whenever we're talking about fluid status, daily weight is always going to be one of your interventions. Vital signs, hypertension, of course. Intake and output. Remember that urine output is going to be a great indicator on how well the kidneys are doing. Patient's diet. So the patient may experience some malnutrition because of so much protein loss in the urine. Now that's not universal for all patients. It really just depends on the patient. Treatment. We are going to treat this with antibiotics because this is an infection, diuretics if necessary, and hypertensives if necessary. And then also supportive care. So supportive care just means whatever the patient needs for that time. If they need pain medication, then pain medication. If they need oxygen, they need oxygen. So just whatever, to keep them comfortable. Sometimes plasmapheresis can be done. This is a machine that filters the blood and takes out some of those bad antibodies or other complement proteins that are in there making this condition worse. So plasmapheresis is not used routinely, it just depends on the patient. And then rest. So the patient should be resting to give the body a chance to recover. Complication we're trying to avoid with glomerulonephritis is renal failure. This can lead to renal failure. If it's not caught early enough or it's not treated early enough, it can definitely have lifelong consequences. So renal failure we are trying to avoid. Teaching, overview of the disease process. How did this happen? How can you avoid it? So if they did get a strep throat infection, then we want to try to avoid that in the future. If they have some type of autoimmune disease, we want to let them know that, hey, you might get this again in the future, so look out for the signs and symptoms. They should take whatever medications they're prescribed on discharge, especially like antibiotics, their antihypertensives. Dietary restrictions. So remember, we want to be really careful with protein when it comes to urine when it comes to renal issues, but our body needs protein no matter what. We can never have zero protein because our body uses that as building blocks for many, many processes in our body. When it comes to this one, if the BUN is elevated, and if you remember, BUN is a direct correlation with protein levels, right? That it's broken down and nitrogen, all that. So if it's already elevated, and you don't need to know numbers, this is just a concept for you to just know for this condition, then you may want to do low to moderate protein intake, but definitely we're limiting sodium and fluid. Okay, so this is one of those conditions we are restricting fluid, restricting sodium, and we're just going to leave protein out of it. We're never going to increase protein beyond a patient's normal intake if they have impaired renal function. And then of course we want to avoid infections, hand hygiene. Next is acute kidney injury. So what is it? This is going to be rapid, abrupt, sudden, and progressive azotemia. So azotemia is a buildup of waste products, just miscellaneous waste products because the kidneys aren't working. They're not able to do their job and get that filtrate and make urine and all that. So things are just building up in the body. There are three major categories of causes of AKI, and you should be familiar. So pre-renal, intrarenal, and post-renal. So first up is pre-renal. So take a look at this picture here on the left. So our kidneys are here, okay? So pre-renal means any problem happening above the kidneys. And look, it's the heart. So the heart is responsible for pumping blood. So if the heart isn't pumping that blood effectively, maybe decreased cardiac output, there's not much coming out of the heart, or maybe there's hypovolemia, there's just not a lot of blood, the patient's really dehydrated, or they had like a bleed and they've lost volume. Those things are going to affect the kidney because the kidney is going to say, hey, where's all my blood? I need blood. I need a certain amount of pressure to work, and the kidney itself needs blood. So those things can cause acute kidney injury. If renal perfusion remains compromised and the kidneys aren't able to compensate, then you're going to have irreversible damage to the kidney, and we don't want that, of course. Intrarenal. So now you see in this picture, we actually have the kidneys colored, right? So this is a problem inside of the kidney. There's damage to the nephrons in the actual kidney. And this is going to be related to nephrotoxic medications, like some antibiotics, not all, but some, iodine-based contrast dye. It can be hemoglobin from red blood cell destruction, or myoglobin from muscle cell destruction. Those are just some reasons. So those things can cause the actual kidney to become impaired. So nephrotoxic medication, like a lot of NSAID use, having a procedure with a contrast dye can cause problems. So one way we can avoid that is by first, if they don't have to get a nephrotoxic med, then let's not give it to them. And also, if they have to have it, then we want to keep them hydrated. We want to keep things moving to dilute that blood. And finally, post-renal. So here in the picture, you see the ureters and the bladder are lit up. So this is something that happens after the kidneys, post-renal. And this is going to be related to an obstruction. So it can be an obstruction anywhere past the kidneys. So the ureters, the bladder, or the urethra. And one big culprit of this is kidney stones and enlarged prostate. It also could be related to trauma or some other kind of benign tumor, or even prostate cancer tumor. Any of those things, anything that causes the urine to backflow. So if you have a really big stone in your ureter and the kidneys are producing urine and that stone is blocking it, the urine will back up, and you can see in the picture as it backs up, it goes back into the kidney and it causes a post-renal acute kidney injury. So we talked about the RAS system. So if you remember, in response to hypovolemia or hypoxia, when the kidneys feel like they're not getting enough blood, not getting enough oxygen, the RAS system is going to be activated. So this is going to cause hypertension, which is going to exacerbate the problem. So phases of acute kidney injury. At the beginning, when that first injury happens, it doesn't matter what the cause of the injury is, we're going to have decreased urine output. Okay, the kidneys are hurting, they're not able to function. We're going to have decreased urine output, less than 400 mLs a day, which is oliguria. Fluid overload, that's going to be one of our nursing problems, fluid overload. So much that they're probably going to have edema, they could have wet lungs, JVD. Electrolyte imbalances, again, we're talking about fluid overload. And metabolic acidosis, because our electrolytes are now being affected, especially that potassium, which is going to stay in, it's not going to be able to come out. Once treatment is on board, we're going to go into the diuretic phase. That's when the kidneys start feeling a little better, and they start diuresing. So we're going to have increased urine output, but it can lead to hypovolemia and hypotension technically, but this is just part of the healing process. So we're acknowledging that they're going to diurese. And then the recovering phase, we hopefully return the patient back to baseline. Their edema will subside and their fluid and electrolytes will hopefully go back to baseline. So signs and symptoms. We are talking about fluid and electrolytes. So signs and symptoms of fluid overload, like I said, edema, JVD, bounding pulse, hypertension. If this is not corrected, all of that extra fluid can put a lot of strain on the heart and lead to heart failure and pulmonary edema. Electrolyte imbalances that we expect with acute kidney injury: high potassium, high phosphorus, high BUN and creatinine, low calcium, potentially low sodium, and low pH, which is going to be metabolic acidosis. Okay, so again, I'm going to keep saying it over and over. When you have an acute kidney injury, the kidneys are upset, they're not functioning properly, fluid overload, electrolyte imbalances, okay? This can lead to not being very hungry, so anorexia, nausea, constipation, or diarrhea, confusion, lethargy, seizures, and coma. And this is really related to the electrolytes as they build up and eventual death. So we need to do something about this. This is from your textbook. It shows the sign, or the manifestation, and then the cause behind it. So I'm not going to go through all of this, but definitely read this on your own. I'm just going to read a couple of them just to get you on track. So for example, fluid overload, that is due to decreases in urine output. Really simple. The fluid isn't coming out, it's all staying in. Increased potassium, impaired secretion. The body's not able to excrete it. Decreased sodium, that is because the kidneys are having a hard time keeping sodium. It's just not, they're not functioning well, things are not staying how they should be, and so on. So you can read through this chart on your own. So what do we do for acute injury? Well, the first thing is to consider what caused it in the first place. Is it because they have low blood pressure? Is it because they are very dehydrated? Are they on some type of medication that's exacerbating this injury to the kidney? Do they have an obstruction? What is it? That needs to be taken care of, so hopefully the kidneys can recover. We want to prevent complications. We're trying to prevent renal failure, and we're trying to prevent irreversible kidney damage. And then assisting in recovery is just supportive care. So your assessments, vital signs. We're talking about fluid status, potentially hypertension. It could even actually, patient can get a infection also, but that is not the primary concern with the AKI, but that could also happen. So we want to assess vital signs. Urine output, of course, we're going to check those labs. Cardiac monitoring. So cardiac monitoring is because they have an electrolyte imbalance, and they're going to have a tendency to keep in potassium. So whenever you have an electrolyte imbalance, especially with potassium, we want to make sure they're on a cardiac monitor. Weigh daily. I hope by now you're listening to this, there's like the same theme over and over because we're dealing with fluid. Weigh daily. Oxygenation, breath sounds, because potential fluid overload and lung and having fluid on the lungs. Peripheral vascular system, so that's like edema and circulation. Interventions, manage the fluid balance, give those meds. We want the patient to be moving if possible. It helps to circulate fluid, breathe easier, so positioning, early ambulation if possible, cough and deep breathe. Skin care because they may have that edema. Nutrition, we need nutrition. We need to consume those building blocks in order to repair our cells. So these patients should have increased calories, but a balanced meal. So they can have carbs, protein, and fat, just balanced, but they should be on a potassium and sodium restriction. This major complication of AKI is hyperkalemia. Hyperkalemia, because that can stop our heart. So that is life-threatening. Patients with AKI, they could need temporary dialysis, just a couple of sessions, just until their kidneys recover. So let's talk a little more about hyperkalemia. So too much potassium decreases the threshold necessary to generate an action potential, which is going to lead to those dysrhythmias and those lethal dysrhythmias like VFib and BTAC or asystole, which is death. So the first sign you're going to see on your monitor is going to be peaked T waves, and that happens somewhere between 5 and 6, potassium of 5 and 6, more so the latter half of like 5.5 and above. So you're going to see like this picture down here, peaked T wave. Then as the potassium continues to rise till about 7.5, somewhere in between, your QRS complex is going to get widened. It's going to become prolonged. And then as it continues to rise, absent P waves and sinusoidal, this is bad. This is, if the patient hasn't had a cardiac arrest yet, they're going to have one very soon. So we're going to try to avoid that. So we are going to be aware that there's lots of medications that we can give to treat hyperkalemia. And if you have a severely high potassium level, we need to do something via the IV route right away. So we are going to give IV calcium gluconate to stabilize those muscle cells in the heart. That's all it's going to do, is to stabilize, just to kind of calm them down so that we can give other medications to decrease the potassium. So some other methods is going to be IV insulin, IV push of insulin plus dextrose together, albuterol and bicarbonate. So all of those things are options. Remember that the IV route is much quicker, so you're not going to want to give a PO route, an oral route for a really high potassium as your first line of treatment, because it's going to take too long. So let's talk a little bit about why we give IV insulin to treat hyperkalemia. So when we give insulin, we are giving that to bring glucose into the cell so that we can use it as energy. But when we do that, when we give insulin and glucose starts to go into the cell, the glucose will actually bring potassium with it because most of our potassium lives inside cells. So if we are hyperkalemic, that means for some reason the potassium has left the cell and it's now roaming around in our blood. We want to bring it back into the cell. Insulin will do that. So we give the insulin and then the glucose will go into the cell and the potassium is going to follow it. So we just have to be careful with hypokalemia because this can cause the patient to dramatically decrease their potassium levels as the potassium is going back into the cell where it should be. And then also, you don't want to give insulin to a patient who already is hypokalemic. So if they already have lower levels of potassium, if our normal level is 3.5 and say they have 3.2, you don't give it. You call the doctor and say, hey, their potassium is low. Do you want to replace the potassium before I give the insulin? Okay, so just because you have an order for it, you still need to do your checks and inform the doctor if you feel it's unsafe. That would be unsafe because a very low potassium is also dangerous, just like a very high potassium. And then we have an enhancing total body elimination of potassium. So potassium can also be excreted from the body in stool, like in our gut. So Kxalate or sodium polycystyrene sulfonate is another way that we can decrease potassium, but it just takes longer. It takes about 5, 6, 7, 8 hours for it to bring down that potassium level. It is a very effective way, but we wouldn't use that as first line treatment if we had a really, really severe potassium level. We could also do IV Lasix. Just remember that diuretics can also hurt the kidney too if you're forcing the kidney to work harder, because that's essentially what diuretics do. It kind of forces the kidney to make urine. So sometimes that can also cause an AKI in some instances. And then emergent hemodialysis. So we can clean the blood with a machine, and if a patient is already a dialysis patient and maybe this is the reason why they have hyperkalemia because they missed a dialysis session, then having a quick dialysis would be good. But if a patient has a really, really high potassium, like 8, then having a quote emergent dialysis may not be emergent enough, especially if they don't already have dialysis access. Okay, so we finished with AKI, so now we're moving on to CKD, chronic kidney disease. So the pathophys on this one, progressive, irreversible loss of kidney function. It happens over time. You don't get CKD in a month or 2 months. This happens over years. And the way that you'll see this is slow increases in both the BUN and creatinine over time. So I will tell you that when we are an older adult, when we are in our 70s and our 80s and 90s, we will all have a degree of chronic kidney disease because over time our kidneys do, the function starts to decline over time, and that's kind of just like a natural process. But with these patients, it's happening a little quicker, right? So slow increases in BUN and creatinine. So they came in to see their doctor's office, every year as for their annual checkup, and every time they come in, their BUN and creatinine is just a little slightly higher, a little slightly higher. Okay, so that could be an indication of chronic kidney disease happening. Risk factors, chronic conditions like diabetes and hypertension. Those top two will always likely lead to some kind of kidney problem. If you have a patient on dialysis in renal failure, 9 times out of 10 they have diabetes and or hypertension. So it is a problem in this country. So education to prevent and treat diabetes and hypertension is always going to be something that you should have in your mind at all times. Okay, high cholesterol, smoking, drug use, NSAIDs, obesity, glomerulonephritis, PKD, lupus, atherosclerosis can all lead to kidney problems. Clinical manifestations, you're going to see that this is pretty much the same as AKI, right? Because essentially it's impaired renal function. AKI is temporary, hopefully. Patients will go back to their baseline. Chronic kidney disease, on the other hand, they're going to live with this and it's progressive. But essentially the kidneys are not working, so you're going to see the same signs and symptoms. So we're going to have problems with sodium and fluid balance, hypertension, heart failure, pulmonary edema, which is essentially fluid overload. Altered potassium, it's going to lead to heart problems, dysrhythmias if left untreated. Impaired metabolic waste exchange, we're going to have that azotemia, things are going to start to build up, and that can lead to coma and death, neuro problems. Altered calcium and phosphorus. So this is from several different issues: bone breakdown, osteodystrophies, defective bone development. That's what it's going to cause. Phosphorus is going to build up, and phosphorus and calcium have an inverse relationship, so calcium is going to be decreased. Decreased acid clearance and bicarb, so our acid-base balance. These patients will tend to be in metabolic acidosis, mostly because of that high potassium level. Some hormone problems, endocrine. Remember what the kidney does, it secretes several different types of hormones which can affect the body systemically. So this can lead to infertility, amenorrhea, which is the cessation of menstruation, hyperparathyroidism, and other thyroid issues, and chronic anemia. So chronic anemia, very, very common. That is from decreased secretion of that erythropoietin hormone. This is a very nice flow map from your textbook. You should go to each column here, each blue box, and follow it down and really remember and understand why this is happening. So let's do a couple together. So sodium and water balance. So chronic kidney disease is going to lead to fluid retention. Fluid is not leaving the body, it's staying in. This is going to lead to hypertension, increased vascular volume, and over time it can lead to heart failure. So everything is connected. Potassium balance. The kidneys aren't going to have the ability to excrete all the potassium, so we're going to end up with buildup of potassium in the blood. So hyperkalemia, that's going to lead to cardiac arrhythmias, which can lead to eventual death. Okay, so again, go through this on your own. It is a recap of everything we just talked about, and just have a good understanding. So diagnosing this, increased creatinine and a decreased creatinine clearance can be protein in the urine, uremia, we can do ultrasound imaging, renal biopsy. So treatment, renal replacement therapy. Renal replacement therapy is dialysis. There's a few types of dialysis. In this class, we're not going to go into depth about the dialysis itself, but just know dialysis is a big kidney machine and it's going to do what our kidneys do. We're very lucky we have a dialysis machine, a kidney machine, because we don't have that for every organ. For example, if your liver stops working, we don't have a liver machine. So people that go into eventual, renal failure, it is a change in lifestyle because you have to have dialysis, but they can still live a long time on dialysis. Okay, back to treatment. So support remaining function of the kidney. So even though they're in chronic kidney disease, they still have some functioning nephrons. So we want to make sure they stay functioning. Treat clinical manifestations, all those things we just talked about, and prevent complications. Surgical management, they may need a kidney transplant. And then some complications of the transplant that we're not focusing on for this class, just making sure they don't reject that transplant, and they'll have to be on medications, immunosuppressants for the rest of their life. So interventions for CKD, vital signs, and I hope you remember why. So fluid balance, the heart rate, the blood pressure, that temperature, all the way around. Pulmonary, cardiac, and peripheral vascular. This, again, I hope this is a review after listening to this. It's all the same concepts. And then post-transplant assessment, monitoring labs. Your interventions, maintain a cardiac monitor because of potential cardiac dysrhythmias, especially lethal dysrhythmias due to that high potassium. Weigh the patient, restrict fluids and sodium, give those medications appropriate. Post-transplant, we're not going to worry about that. Teaching, if they're on dialysis, don't miss your dialysis appointments because your toxin level is going to really build up in the blood and can cause coma and death. Dietary restrictions, you can always tell when your patient has had a high salt diet because they're retaining all the fluid. So very important. Diet plays a very big role in kidney disease. Signs and symptoms of CKD and complications, so let them know if they're having worsening fluid overload, if they're having like heart palpitations, that type of thing. Avoid nephrotoxic substances. Their kidneys are already not the best, so let's not make it worse. Daily weight and post-transplant, again, we're not going to worry about that. So this is a nice chart from your textbook. It gives you the comparison of AKI and CKD. Lots of similarities, a couple little differences, so please take a look at that.